Welcome to this critical appraisal of the fluid trial, a significant crossover study comparing hospital-wide lactated ringer solution versus normal saline. As you can see from the title, this research, published in the New England Journal of Medicine, addresses a fundamental question in fluid management for hospitalized patients. This presentation will delve into the trial's design, methodology, and findings, providing a comprehensive overview. Our focus will be on understanding its implications for clinical practice, particularly within our local context, at Santosh Medical College, Ghaziabad. We will examine the strengths and limitations of this pragmatic, randomized controlled trial to draw informed conclusions. Let's begin by outlining the structure of our appraisal. Our appraisal will follow a structured approach as outlined on this slide. We'll start with an introduction, exploring the clinical question, background, and rationale behind crystalloid choices. Next, we will examine the methods, detailing the pragmatic cluster randomized crossover design, eligibility criteria, and statistical plan. Following that, we will present the results covering participant baseline characteristics, primary and secondary outcomes, and subgroup findings. Finally, our discussion will cover methodological strengths, critical limitations, post hoc Bayesian reanalysis, and the local applicability of these findings to North Indian and Ghaziabad patients. This systematic breakdown will ensure a thorough understanding of the trial. Let's now move into the introduction section, where we will lay the groundwork for understanding the fluid trial. This segment will cover the essential background information, highlight the clinical need that prompted this research, and explain the rationale behind its design. Understanding these foundational elements is crucial for a comprehensive appraisal of the study. This paper is highly relevant due to a significant clinical problem. Normal saline, a common crystalloid fluid, has high chloride content. This can lead to hyperchloremic metabolic acidosis in hospitalized patients, while previous large trials, as seen in the referenced article, show balanced crystalloids improve major adverse kidney events in critical care. It remains uncertain whether hospital-wide use produces patient-important clinical outcomes outside the ICU. This uncertainty forms a critical evidence gap. Therefore, the core research question addressed by the fluid trial is whether a hospital-wide policy of using lactated ringers solution compared to normal saline reduces death or readmission within 90 days after index admission. This question guides our entire appraisal. To fully understand the clinical question, let's break it down using the PICO framework as shown on this slide. Our P for population includes hospitalized patients in academic and community hospitals requiring intravenous fluids, admitting at least 1,500 patients per period, and having level 2 or 3 ICU capacity. The I for intervention is a hospital-wide policy of administering lactated ringer solution from admission through discharge. For C, the comparator is a hospital-wide policy of administering normal saline, 0.9% sodium chloride, as the main crystalloid fluid. Finally, the O for outcome is a composite of death from any cause or readmission to the hospital within 90 days after index admission. This clear framework helps define the scope of the trial. Now we transition into the methods section, which details how the study was conducted. Here, we will explore the study population, the specific eligibility criteria for participation, the outcomes that were measured, and the statistical approaches used for analysis. Understanding these methodological aspects is vital for evaluating the internal and external validity of the trial. Looking at the study design, this was an investigator-initiated, open-label, pragmatic, 2-period, 2-sequence, cross-sectional, cluster randomized crossover trial. Hospitals were assigned 2 sequences of either lactated ringers followed by saline or vice versa, with each active period lasting 12 weeks and a 1 to 2 weeks washout. 7 academic and community hospitals in Ontario, Canada, participated, representing a diverse patient population. For bias control, individual patient consent was waived due to minimal risk, and while clinicians were open label, outcomes were independently analyzed from administrative databases. Adherence was monitored daily through inventory tracking and automatic substitution orders in the electronic health record. This pragmatic cluster crossover design, where randomization occurred at the hospital level, ensured hospital-wide implementation of the assigned fluid. Let's examine the eligibility criteria for the fluid trial as displayed here. For inclusion, hospitals needed to admit at least 1,500 patients per trial period and have level 2 or 3 ICU capacity. All patients with an index admission during active study weeks were included, regardless of their actual fluid exposure, reflecting a pragmatic intention to treat approach. Exclusion criteria included patients younger than 1 month, those with missing birth dates or not meeting the index admission definition, and admissions during run in or washout periods. The definition of an index admission was crucial. A patient's first admission with no prior hospital admission in the preceding 90 days, which prevented multiple counting of the same patient. These criteria helped ensure a relevant and clean data set for analysis. Moving on to the trial endpoints, this slide outlines the primary, secondary, and safety outcomes. The primary outcome was a composite of death from any cause or readmission to the hospital within 90 days after index admission, with data validated to over 99% accuracy in administrative databases. Secondary outcomes included individual components of death and readmission, clinical outcomes like initiation of dialysis, and emergency department visits within 90 days, and health system outcomes such as hospital length of stay and discharge destination. Safety outcomes focused on serious adverse events related to fluid administration reported through principal investigators and routine safety committee meetings. These comprehensive endpoints aimed to capture a broad range of patient important effects. Let's review the statistical plan and power for this trial as depicted in the boxes at the top of the slide. The original target sample size was 16 sites, aiming for approximately 144,000 admissions to achieve 80% power to detect a 1% absolute difference in outcomes. However, the study was terminated early after only 7 hospitals completed both periods due to infeasibility during the COVID-19 pandemic. The primary analysis used regression, modeling the trial period as binary, and including intervention and hospital as independent variables, with 5 degrees of freedom. Adjustments were made for age, sex, case mix group, Elix-Hauser comorbidity score, and ICU admission within 1 day using the 2-stage Hayes-Moulton method. This early termination significantly impacts the power and interpretation of the results. Now, let's consider the protocol adherence and achieved exposure summarized in the boxes on this slide. Adherence was notably asymmetric. Lactated ringers group showed 78.2% adherence, while the normal saline group achieved 93.6%. This meant that non-assigned fluids accounted for 21.8% of fluid use during the LR periods, indicating considerable treatment contamination. A total of 43,626 patients were analyzed, and importantly, there were 0 missing values for the primary composite or secondary outcomes. Reflecting high data completeness, all eligible patients were analyzed under the intention to treat principle, regardless of their actual fluid exposure, which is crucial for a pragmatic trial. This varying adherence, however, could dilute any potential treatment effect. In critically appraising the methods for internal validity, we identify both strengths and limitations. Methodological strengths include successful cluster randomization, which balanced baseline characteristics, and the use of validated population-based health registries, minimizing loss to follow-up and detection bias. Furthermore, ICS analysts were blinded to randomized sequences, reducing analytical bias. However, significant limitations exist. Early stopping at 7 of 16 planned clusters left the study underpowered to detect a 0.5% to 1.0% absolute risk reduction. Asymmetric adherence with 21.8% non-compliance in the lactated ringers group diluted the treatment effect. The open label design, while pragmatic, could theoretically introduce co-intervention bias, though hospital-wide policies likely mitigated this. Overall, the trial was well designed, but faced significant challenges that impact its internal validity. Now, we transition to the results section, where we will present the key findings of the FUID trial. This part will cover the patient enrollment details, the baseline characteristics of the participants, and the outcome data observed during the study. Understanding these results is essential for interpreting the efficacy and safety of the interventions. Let's walk through the trial design schema presented in Figure 1. The study consisted of two active 12-week periods. Before each period, sites had 1 to 3 weeks to stock the assigned fluid hospital-wide, followed by a 1-week run-in period for staff familiarization and automatic substitution order implementation. Patients admitted during these run-in periods were not included in the analysis. The active trial periods, weeks 2 through 13, included all patients with an index hospital admission unless they met exclusion criteria. Each active period was followed by a 1 to 2 week washout period, during which patients were also excluded from analysis to ensure consistent fluid exposure throughout a patient's hospital stay. This crossover design aimed to minimize confounding factors within each hospital. This flowchart, Figure 2, illustrates the screening, randomization, and analysis process for the fluid trial. Out of 7 hospitals screened, all 7 underwent randomization. 4 hospitals were assigned to receive normal saline first, then lactated ringers, while 3 hospitals received lactated ringers first, then normal saline. The chart details the number of patients admitted during each period and the reasons for ineligibility, such as previous admissions within 90 days, age constraints, or data quality concerns. Ultimately, a total of 43,626 patients were analyzed across both treatment groups. This rigorous accounting of patient flow ensures transparency and helps us understand how the final analysis population was derived from the initial admissions. Table 1, displayed here, summarizes the baseline demographic and clinical characteristics of the patients. As you can see, the lactated ringers and normal saline groups were remarkably similar across various parameters. For instance, the mean age was 58.5 years in the LR group and 58.7 years in the saline group. Female sex distribution was also very close at 57.6% versus 58.4%. Residence, income quintiles, and case mix groups like medicine, surgery, and pregnancy/childbirth showed virtually identical distributions. Even the mean Elix-Hauser comorbidity index scores were balanced at 2.6 and 2.8, respectively. This exceptional balance in baseline characteristics is a strong indicator of successful randomization and enhances our confidence in the study's internal validity. Regarding baseline comparability, the randomization succeeded exceptionally well. Patient characteristics were very well matched. The mean age was 58.5 years in the lactated ringers group and 58.7 years in the normal saline group, with female sex at approximately 58% in both. Socioeconomic balance was also excellent, with similar income quintile distributions and identical case mix groups, including medicine at about 40%, surgery at 41%, and pregnancy, childbirth at 17%. The comorbidity index was balanced with a mean Elix-Hauser score of 2.6 in the lactated ringers group versus 2.8 in the saline group. This thorough imbalance analysis confirmed no clinically or statistically meaningful differences, reinforcing the success of the cluster randomization. This strong baseline comparability ensures that any observed differences in outcomes can be more confidently attributed to the fluid intervention. Table 2, displayed here, summarizes the cluster-level analyses for both primary and secondary outcomes. For the primary composite outcome of death or readmission within 90 days, the lactated ringers group showed an incidence of 20.3% compared to 21.4% in the normal saline group. The adjusted mean difference was minus 0.53 percentage points, with a 95% confidence interval of minus 1.85 to 0.79 and a p-value of 0.35, indicating no statistically significant difference. Similarly, for secondary outcomes such as death, readmission, emergency department visits, and initiation of dialysis, there were no significant differences between the groups. Hospital length of stay and discharge to a facility other than home also showed comparable results. These findings suggest a neutral effect of lactated Ringer's solution compared to normal saline on these outcomes. Let's interpret the efficacy results presented here. For the primary composite outcome of death or readmission within 90 days, the incidence was 20.3% in the lactated Ringer's group versus 21.4% in the saline group. The adjusted difference was minus 0.53 percentage points, which, with a p value of 0.35, indicates a statistically non significant finding. The relative risk was 0.97 with a 95% confidence interval of 0.90 to 1.05, further confirming no statistically significant difference between groups. While the point estimate slightly favored lactated Ringers, the wide confidence interval encompasses both potential benefit and potential harm. Pragmatically, this means a hospital wide policy of substituting normal saline with lactated Ringers did not yield a significant decrease in 90-day death or readmission. Moving to the secondary efficacy and clinical outcomes, the results consistently showed no significant differences between the two fluid groups. Death within 90 days occurred in 6.9% of lactated Ringer's patients versus 7.6% of saline patients, with an adjusted difference of minus 0.26 percentage points and a relative risk of 0.97. Readmission within 90 days was 15.1% in the LR group versus 15.4% in the saline group, yielding an adjusted difference of minus 0.06 percentage points and a relative risk of 0.99, a neutral result. Initiation of dialysis also showed no significant difference. Emergency department visits were 21.2% for LR versus 21.0% for saline, with an adjusted difference of 0.28 percentage points and a relative risk of 1.01. Furthermore, health system outcomes like hospital length of stay and discharge to a facility other than home were similar. Regarding safety and adverse events, the trial's reporting system involved sites monitoring serious adverse events, or SAEs, through routinely scheduled safety committee meetings and morbidity and mortality rounds. Importantly, 0 serious adverse events related to fluid administration were reported to the central coordinating site in both treatment arms. This indicates excellent tolerability of both fluids. However, there was a critical data gap. The trial did not report specific lab-based harms, such as the incidence of hyperkalemia or metabolic acidosis. This omission limits our full understanding of potential electrolyte imbalances. Despite this, the overall safety verdict suggests no significant adverse events were observed, ensuring confidence in the general safety of both fluids. Figure 3, displayed here, illustrates the subgroup analysis presenting forest plots of the absolute risk difference for the primary outcome. The results were generally consistent across all pre-specified subgroups, including age, sex, comorbidity quartiles, and case mix groups. For instance, both female and male subgroups showed similar risk differences, slightly favoring lactated Ringers, but none were statistically significant. The age groups also displayed consistent trends, with the exception of the greater than 80 years category, which showed a statistically significant reduction in risk difference favoring lactated Ringers with a minus 3.41% difference. This particular finding warrants further investigation, as it suggests a potential benefit in a vulnerable population. In appraising the subgroup analysis, we found that results were generally consistent across all pre-specified subgroups, including age, sex, comorbidity quartiles, and case mix. For example, sepsis patients, a subgroup of 437, showed consistent results with a risk difference of minus 1.23% and no statistically significant benefit, while a small subgroup of 90 traumatic brain injury patients had a point estimate of minus 3.48%. This did not show the increased mortality concern previously seen in trials like SAFE. It's crucial to note that all subgroups, while pre-specified, were underpowered due to small sample sizes, meaning their findings are strictly hypothesis generating and require further validation. This limitation means we cannot draw definitive conclusions from these subgroup results alone. In our critical appraisal of the results, we identified several strengths and limitations regarding efficacy. A major strength is the large database, analyzing 43,626 patients through a centralized system, ensuring virtually no loss to follow up for the primary outcome. Additionally, there was clinical consistency as individual components like death, readmission, and dialysis were directionally consistent with the primary composite point estimate. However, significant efficacy limitations exist. The study was underpowered due to early stopping at 7 of 16 planned hospitals, reducing its ability to detect a 0.5% to 1.0% absolute risk reduction. Exposure dilution from 21.8% noncompliance in the lactated ringers arm likely attenuated any true physiological difference. Finally, the lack of fluid volume data per patient limits our ability to assess dose response relationships. The overall verdict is that the neutral primary composite outcome is definitive for this trial, but a small benefit cannot be entirely ruled out due to the wide confidence intervals. This slide provides a summary of the risk of bias to ROB2 assessment across 5 key domains. For domain 1, randomization process, we assigned a low risk as the central block randomization stratified by hospital cluster resulted in exceptionally well-balanced baseline covariates. Domain 3, missing outcome data, and domain 4, measurement of the outcome, also received low-risk ratings due to registry-based tracking with zero loss to follow-up and objective outcome validation. Domain 5, selection of the reported result, was low risk because the trial followed a pre-published protocol and statistical analysis plan. However, domain 2, deviations from intended interventions, raises some concerns. This was an open-label study with substantial non-adherence in the lactated ringers arm at 78.2% adherence and potential for cross-contamination. Consequently, the overall risk of bias judgment for this trial is some concerns, primarily driven by the issues in domain 2. Let's review the grade certainty of evidence for this trial as displayed on the left. The final certainty is moderate, meaning we are moderately confident in the effect estimate. The true effect is likely close to the estimate, but there remains a possibility that it is substantially different. This outcome, the composite of death or readmission within 90 days after index admission, was assessed against 4 criteria. For risk of bias, there was no downgrade, despite concerns in domain 2 regarding non-adherence. This reflects pragmatic, real-world implementation. Inconsistency also saw no downgrade, as subgroup point estimates were directionally consistent. Indirectness received no downgrade, as the study directly evaluated patient-important clinical outcomes. However, imprecision led to a downgrade of 1 level due to wide confidence intervals that cross both the null and the clinically important threshold of a 1% absolute difference, primarily caused by the early study termination. We now move into the discussion section, which will synthesize our findings and place them within a broader context. In this segment, we will explore how the fluid trial compares to other key crystalloid trials, examine its implications for current clinical guidelines, and consider the results of any Bayesian reanalysis. This discussion will help us understand the trial's contribution to the existing body of evidence. This slide presents a chronology of key crystalloid trials, placing the fluid trial in context. Earlier trials like SAFE 2004 in the ICU showed no difference in 28-day mortality, but increased mortality in traumatic brain injury with albumin. SPLET 2015 in the ICU found no difference in AKI or renal replacement therapy between plasma light 148 and normal saline. SMART 2018 in the ICU demonstrated a significant 1.1% absolute reduction in major adverse kidney events with balanced crystalloids. SALT-ED 2018 in the ED showed a similar reduction in MAKE-30 for non-critically ill patients. BASICS 2021 in the ICU again found no significant difference in 90-day mortality, showing equivalence. Finally, Fluid 2025, a hospital-wide trial, reported no significant difference in 90-day death readmission, with its results diluted by non-adherence and early termination. This overview highlights the evolving understanding of crystalloid use across different patient populations and settings. Regarding the current guideline consensus on crystalloids, as you can see on this slide, several key recommendations exist. The Surviving Sepsis Campaign 2021 weekly recommends balanced crystalloids over normal saline for adult sepsis or septic shock resuscitation based on moderate quality evidence. Clinical practice guidelines also suggest balanced crystalloids for patients with diabetic ketoacidosis or those needing large volume resuscitation to prevent hyperchloremic acidosis. For general medical wards, however, there is no strong guideline recommendation for routine fluid choices, emphasizing that individual patient factors such as cardiac status, renal function, and electrolyte balance should dictate fluid selection. The consensus verdict is that while balanced crystalloids are preferred in critical care and sepsis, normal saline remains acceptable and widely used in general medical wards. Now, we transition to the applicability and takeaways section. Here, we will focus on translating the findings of the fluid trial into practical insights. We'll discuss its relevance to local clinical settings, consider how it might inform ward guidelines, and summarize the key lessons learned. This section aims to bridge the gap between research and real-world practice. Considering the local applicability for North Indian patients, we see both opportunities and barriers. In terms of opportunities, both lactated ringers and normal saline are widely available and extremely cheap in public and private hospitals, making either a feasible option given the high prevalence of sepsis and critical illness in our region. Using lactated ringers as a primary fluid aligns with global resuscitation recommendations. Furthermore, avoiding hyperchloremic metabolic acidosis is particularly beneficial for our patients with pre-existing renal impairment, which is common. However, there are significant barriers and safety concerns. Misconceptions about lactated ringers, specifically that it contains lactic acid rather than lactate, can lead clinicians to mistakenly avoid it in lactic acidosis. Also, lactated ringers can transiently increase blood lactate levels, complicating monitoring in patients with septic shock or hepatic failure. In the Ghaziabad clinical context, while RL is generally safe and cheap, we cannot assume it is superior to saline for routine ward patients. Fluid choices must be individualized. Let's consider the clinical takeaways for various care settings as presented on this slide. For outpatient clinics or OPD, it's crucial to assess fluid and electrolyte status before prescribing home hydration or IV fluids. Individualized fluid choices are key. Normal saline is appropriate for volume depletion with hypochloremic alkalosis, such as from severe vomiting. In inpatient wards, using lactated ringers or balanced crystalloids as the default maintenance fluid can prevent hyperchloremic acidosis. Routine large volume saline should be avoided unless treating severe hyponatremia or hypochloremia, and serum electrolytes should be monitored every 24 to 48 hours during active fluid therapy. For the ICU and high dependency units, or HDU, balanced crystalloids are preferred for initial resuscitation in sepsis or septic shock. However, lactated ringers should be avoided in patients with severe hepatic failure or hyperkalemia. Therapy must be individualized based on mean arterial pressure, cardiac output, and real-world clinical endpoints. Now, let's open up the discussion with some key questions for our journal club, as outlined on this slide. First, regarding pragmatic compliance, how do we effectively address fluid non-adherence and automatic substitution overrides in our clinical settings? Second, concerning ward versus ICU choices, should we standardize fluid policies hospital-wide, or should general ward choices remain separate from ICU resuscitation choices? Third, to tackle lactate confusion, what educational strategies can we implement to resolve the clinical misunderstanding surrounding lactated ringers use in lactic acidosis? Finally, regarding power and trial design, how does the early termination of the fluid trial affect our trust in its neutral conclusions? These questions will guide our thoughtful conversation and help us apply these findings to our practice.